Good evening, ladies and gentlemen. I'd like to welcome you to this evening CME by KSA, noting that it will be our third CME for the year by KSA. I am Dr. Leslie Gasare. I'll be the host of today's CME. And I'd like to welcome our presenter for the day, who's our very own, a very senior lecturer of the Department of Anaesthesia in the University of Nairobi, Dr. Patrick Olang, who also is an obstetric anesthesiologist and manages pain. And our sponsor for this evening is Sanofi. And I'd like us we'll start with a presentation by Daktari, and then we'll have a keynote from our sponsors. Thank you. Daktari, please go ahead.
Thank you very much, Dr. Gisare, for that introduction. I'm happy to be here again to discuss a common problem that we face, a problem that we have been unable to get guidelines for. But the more we talk about these things, the more we find solutions. And I'm looking forward to a time when we shall be able to find solutions for this very important subject. So I need to say that this presentation has been facilitated by Sanofi. That is my outline. There will be an introduction. Then we shall talk about risk factors for DVT and VTE, which is venous thromboembolism. Then we'll talk about the risk assessment for DVT. Then we are going to talk about the Caprini score for risk assessment, one of the risk assessment methods for DVT and VTE. Then, as I told the sponsors, I would like to talk mainly about VTE and pregnancy, because I do a lot of obstetric work, and I feel more comfortable talking about this problem in the obstetric and gynecological population. That doesn't mean that it does not affect the other members of our population, and therefore we should be able to extrapolate many of these factors to the general population. And we are going to talk about how we reduce the risk of VTE during pregnancy and in the puerperium. And this is something that we are going to give even examples of what we have seen. Then we'll talk about which agents should be used for the thromboprophylaxis. Now, once we have identified that there is indeed a problem of thromboembolism in relation to anesthesia and surgery, then we need to find out which agents should be used, and particularly in the pregnant population. Which women should not be given low molecular weight heparins for thromboprophylaxis. Then we are going to talk about the Royal College of Obstetricians and Gynecologists Green Top Guideline, which was given in April 2015. It has not been reviewed, so we go by what remains there. Then we are going to have our conclusion and take-home messages. And these take-home messages will be preceded by 2 case scenarios that I've experienced and have felt very strongly that maybe we could have done something to prevent them. So globally, venous thrombosis occurs in about 1 per 1,000 individuals per year. That's global. So it's not that bad. It usually affects the deep veins of the leg, but may occur in other sites, such as the upper extremities, cerebral sinus, liver, portal veins, or even retinal veins. It may also occur in the superficial veins, usually in the legs, in the form of varicose veins. And then we also must take note that thrombosis is a serious disorder. It may be fatal by pulmonary embolism, although this is rare if we look at the general population, because the case fatality rate of venous thrombosis is estimated at 1% to 2%. When we are talking about the world population, that 1% is not a small number. Predilection of thrombosis occurring in the legs is the result of the upright position of man with the resulting slow anti-gravitational flow of blood in the legs of the leg, in the veins of the leg. A common and often disabling consequence of DVT is post-thrombotic syndrome. These are symptoms ranging from discoloration to pain and ulcerations. Because thrombosis is not very rare and often has serious consequences, prophylactic treatment is focused on preventing fast events and recurrences through adequate knowledge about risks and risk factors. Overall, the presence of VTE in pregnancy is estimated at 0.5 to 2 per 1,000 pregnancies, and it accounts for 1.1 deaths per 100,000 pregnancies. Remember, pregnancy by itself is not a disease, it is a condition, and there should never be any reason why a pregnant woman should die. For whatever reason, we must try all means to prevent death through pregnancies. Approximately 75 to 80% of embolic events in pregnancy are venous. Slow circulation because of pressure from the uterus, reducing the flow through the iliac vessels, and that therefore means that with stasis, there is greater risk of thrombosis. The two manifestations of venous thromboembolism are deep venous thrombosis and pulmonary embolus. Deep vein thrombosis is completely treatable if caught in time, but the symptoms aren't always easy to spot. And that is why many times your patient will be normal, maybe even discharged, or when the patient goes to the washroom and applies Valsalva maneuver, they collapse in the toilet, and that definitely will be a pulmonary embolism that has occurred because there was a deep venous thrombus somewhere that was not detected or was not suspected and has dislodged and caused that pulmonary embolism. And once it is in a major vessel, pulmonary vessel, there is nothing one can do. It's important to identify which patients are most likely to develop it ahead of time and decide on what prophylaxis, whether it is mechanical or anticoagulant or both, that you should apply. While the US national guidelines endorse assessing VTE risk in all hospitalized medical patients through use of various risk assessment models, there is currently no widely accepted standard by which to perform this evaluation. The Joint Commission and the Centers for Medicare and Medicaid Services in the US have introduced a performance measure for VTE prophylaxis in hospitalized medical patients. This measure requires that clinicians should either provide a form of VTE prophylaxis or document reasons why they should not provide VTE prophylaxis. And that is America for you because of the more and more litigations that they have, so they must protect their backs. Women are 5 times more likely to develop deep vein thrombosis during pregnancy than when not pregnant. VTE can affect men and women of all ages, races, and ethnicities. It does not discriminate. People at the highest risk will include those with cancers, especially cancer of the pancreas, cancer of the lungs, the ovary, the stomach, lymphomas, and adenocarcinomas. Those having major surgery or anyone with major trauma, such as fractures like pelvic, hip, or long bone fractures, or patients who are just immobilized for whatever reason, those who are just lazy, they don't want to exercise, are also likely to develop deep vein thrombosis. Hospitalization is often associated with immobilization, and hospitalization for any reason increases the risk of deep vein thrombosis and hence VTE. Heart conditions such as heart attack or congestive heart failure will also bring the risk of VTE because it minimizes one's ability to exercise, one's ability to move around, and once you are sedentary and blood flow, especially in the lower limbs, is not very active, you tend to have a risk of thrombosis. Chronic conditions, including high blood pressure, diabetes, and kidney disease, also predispose to VTE. Lower extremity paralysis due to spinal cord injury or myopathies have also been noted to increase the risk of VTE. Infections such as the virus that causes COVID-19 pneumonia have also been noted, and those who manage patients with COVID pneumonia will agree that they were coming with very high D-dimers and they were being given very high doses of anticoagulant because one of the most likely things to kill them was deep vein thrombosis leading to thromboembolism. So risk assessment for DVT. Initial VTE risk assessment must be repeated 24 hours later and regularly thereafter. So when you go to review your patient, always try to get a possible history of risk of VTE. Examine particularly the lower limbs, particularly the calves. You may see swelling. You may see something that may make you suspicious. And that should be done regularly. I see particularly the obstetricians, one of the things they write in their notes on the first post-operative day after cesarean section or even after some of the gynecological procedures is there is no calf swelling and no calf tenderness. Can we all make that as one of our objectives when we go to do our post-operative review? Let us not just stick to nausea and vomiting and pain and discomfort as the only thing that we look for in the post-operative period when we go to see the patient. Now, there are many ways of risk assessment, but I've picked one, the Caprini scale, which has a high sensitivity for screening high-risk DVT patients. It is currently used widely in hospitalized patients, particularly in the Western populations. Due to ethnic differences between the East and the West, the risk factors may not be completely applicable in some populations, especially the Chinese, for example. As a study done in 2019 and another one in 2017 showed that the Chinese are different in terms of their risk assessment for VTE. The Caprini score was originally developed for assessment of VTE risk in surgical patients only. But now we do VTE risk assessment in medical patients and in surgical patients. It is key to cutting down on the prevalence of thrombosis. The Caprini score is used to determine when and how one should administer thromboprophylaxis to the patient. It sums up individual risk factors, placing patients into 4 categories. One is the low-risk patient. The low-risk patient should just be encouraged to move up and down. The moderate risk patient, that is 2 points on the Caprini scale, those patients may need to be advised of the risk, and even these may not necessarily require thromboprophylaxis because they may, unless of course they have a history of previous VTE. Then we have the high risk and the highest risk, those with 3 to 4 points and those with more than 5 points. What does the scale look like? If a patient has a stroke, then that's a high risk, one of the highest risk cases, because on the Caprini score, that patient will score 5. Acute spinal cord injury, less than 1 month, will be a 5. Hip, pelvis, and leg fracture, less than a month, 5. Multiple trauma, less than a month, 5. History, previous history of DVT or pulmonary embolism scores 3. And when they score 3, as I have said, it means that they are at high risk, and that's the kind of patient you should give thromboprophylaxis. Then, if you have a patient who has developed, who has a history of thrombophilia, that is high risk. Patient who has had heparin-induced thrombocytopenia will have a risk of 3. Age between 61 and 74 will get a 2. Positive history of cancer, a 2. Immobilizing plaster cast will be 2. Patient confined to bed more than 72 hours will have a 2. Age between 41 and 60 years, you give a 1, so that's very low risk. Congestive heart failure, 1. COPD or abnormal pulmonary function, 1. Inflammatory bowel disease, 1. Severe lung disease, 1. Acute myocardial infarction, 1. Sepsis, 1. And most of these other ones you are seeing are 1, 1, 1. But remember, somebody can have 1 on in one aspect and a 4 in another aspect. You combine those, you get a 5. So those ones become highest risk. So that's basically some of the things. If a patient comes in with a central venous catheter at the time of admission, you give them a 1. They are at risk. It means that there's something happening that has made them have a central venous catheter. Either it is for chemotherapy or it is for some feeding, or it is for some medications, and that tends to be a sick patient who is likely to be confined in bed. And those are some of the things that one must consider in the Caprini score. A study published in the Current Opinion on Pulmonary Medicine found the risk of a fatal pulmonary embolism was reduced by 62% in patients who underwent prophylaxis with low-dose anticoagulants. You reduce the risk by more than 50% by just making sure that you are alert to the fact that the patient is at high risk of developing thrombosis and VTE. The same study found the risk of symptomatic DVT was reduced by 53% by giving thromboprophylaxis. However, there's still some debate surrounding the use of anticoagulant prophylaxis, due largely to concern about patient bleeding. So when you have a patient whom you think is high risk, many times you may need to discuss with your surgeon when you want to resume or when you want to start anticoagulation. I normally would consider the highly obese, the very obese patients, and now we are getting quite a number of obese patients in our population, a patient who is likely to remain immobile, that those are patients that I will not even wait to discuss, and I would like to put them on anticoagulant. A patient who comes with preoperative anticoagulant therapy, I also want to start anticoagulant therapy as soon as it is feasible. And again, that one you don't compromise, because we have seen some bad results, which I will give examples of. While it is true that anticoagulants can lead to bleeding, this is true, no one dies from receiving prophylactic doses of anticoagulants. They will always survive. And if you use the anticoagulants judiciously, I think there is no major risk. Women who are pregnant or have just had a baby are at greater risk of developing a blood clot. The risk is greater in the presence of some of the following other factors. If a patient has had previous blood clots, if a patient has a genetic predisposition to VTE or a family history of VTE, especially in the first degree relative like a parent or a sibling, then they are at a high risk of developing VTE. Obesity, immobilization such as bed rest and long distance travel. The long distance travel we know about. So there must be some way of doing thromboprophylaxis. And we know we can do thromboprophylaxis with a mechanical means or with a chemical means. And if there is really no other reason, like if you are traveling from here to, say, Europe, and you are going on an 8-hour flight, ideally you should wear some TED stockings, especially if you think you are at risk, if you are the kind of person who is not very active, maybe you have already got some form of arthritis, so you hardly do a lot of walks, you spend a lot of time behind the desk, you spend a lot of time in the car, and so on and so forth. One has to be very careful. Patients with multiple births have a high risk. Older maternal age, those who get pregnant when they are around 40, or even those who are about 50 and still get pregnant. These days, they can get pregnant through IVF, and that has had an effect on some of these patients getting complications. Other medical illnesses during pregnancies like cancers and serious infections, or even eclampsia and preeclampsia can predispose to VTE. All women who undergo a documented assessment of risk factors for VTE, all women should undergo a documented assessment of risk factors for VTE from early pregnancy. So this is a conversation which we need to have with our colleagues in the obstetric field. A patient with previous VTE, that is not the kind of patient you want to spare your thromboprophylaxis from. Thrombophilia associated with VTE, this may be hereditary or acquired. Those patients, you must give thromboprophylaxis. VTE associated with antiphospholipid syndrome, which I see quite a bit now. I see quite a bit of patients who have got infertility due to antiphospholipid syndrome, and luckily, it has been found that they need to be put on anticoagulants as a way of preventing recurrent pregnancy losses. So in a way, they are already protected by managing their condition. Pregnant women with antiphospholipid syndrome or prior VTE or arterial thrombosis should also get thromboprophylaxis. So you need to prevent recurrent VTE as much as possible. High-risk women not on warfarin or other oral anticoagulants should be advised to start low molecular weight heparin as soon as they have a positive pregnancy test. And there are many patients who may be on anticoagulants for whatever reason. Some have stents, some have previous heart surgery, and therefore they have artificial valves. Some have all sorts of conditions which make them require anticoagulants, and for that reason, you need to provide them with thromboprophylaxis as soon as you meet them and they are pregnant, and maybe you have been told to go and discuss with them about, these days there are patients who want to discuss about epidural for labor. So very early in the pregnancy, they say they want to talk to somebody who can give the epidural. You need to discuss with them. And if they are already on anticoagulants, that's a very important discussion you may want to have with them. Stratification of women with previous VTE is important. Testing for thrombophilia in women with prior VTE is important. Asymptomatic heritable thrombophilia may just appear. And of course, many times in pregnancy, you want to test for antiphospholipid antibodies. This is very common when patients have infertility issues and they tend to be tested for antiphospholipid antibodies. And this is something, as an anesthetist, you should be keen on. So even the first trimester has its risk factors. A patient with a hyperemesis, patients on with ovarian hyperstimulation syndrome, patients who are on IVF, those are patients who are at risk, and one needs to think of thromboprophylaxis. Thromboprophylaxis during labor and delivery, including the use of regional anesthesia. There are patients who will come when they have been taking their regular thromboprophylaxis. So when they come, they are in labor, they may have been taken the last dose of their medication. You need to think about that. Then you need to discuss the possibility of using regional anesthesia in the presence of previous use, recent use of low molecular weight heparin in a patient who is, say, going for cesarean section. Regional techniques should be avoided if possible until at least 12 hours after the previous prophylactic dose of low molecular weight heparin. The advantage with low molecular weight heparin is that it gets out of the system very fast. Actually, some books say that within the last 6 hours of taking low molecular weight heparin, the patient may actually not have a major risk of developing any complications related to regional anesthesia. But one needs to be careful, because even if it was going to happen anyway without your injection, then it will easily bounce back on you. So you must exercise caution and be on the side of caution. Low molecular weight heparin should not be given for 4 hours after use of spinal anesthesia or after the epidural catheter has been removed, and the catheter should not be removed within 12 hours of the most recent injection. So if your patient got the last dose of thromboprophylaxis less than 12 hours earlier, and you have gone ahead and delivered the patient by whatever means, whether it was epidural analgesia or whether it was a cesarean section, you first must remember not to remove the catheter before 12 hours have elapsed from the last dose, which usually be maybe 4 hours after the surgery or after the delivery. So you should be able to remove it in good time. And then you should be able to start your patient on thromboprophylaxis as soon as possible, remembering that pregnancy by itself increases the risk of thromboembolism, and you want to be cautious. When a woman presents while on a therapeutic regimen of low molecular weight heparin, regional techniques should be avoided for at least 24 hours after the last dose. So one has to be very cautious, because if you give a regional anesthetic and your patient develops a spinal thrombosis, then you know that will escalate the care of the patient, and it would not be fair for you to be judged on an issue like that, unless, of course, you didn't take the history, which again should be avoided. It cannot be an excuse that you did not know that your patient had been on thromboprophylaxis. So what am I saying? I'm saying you must take history of the medications the patient is taking. Many times as an anesthesiologist, you go to the patient and they will tell you, my doctor knows what drugs I use, so they will not tell you. Or if they didn't tell you and you discover, they say, I thought my doctor knew, so I didn't think it was important to tell you. So always be cautious and be proactive in getting all the information that the patient might have, because at the end of the day, it is between you and your patient and the profession. The first thromboprophylactic dose of low molecular weight heparin should be given as soon as possible after delivery, provided there is no postpartum hemorrhage and regional anesthesia has not been used. That cannot be belabored beyond that point that I've made. Reducing the risk of thromboembolism during pregnancy and puerperium is important. Thromboprophylaxis after delivery, you should consider it necessary for your patients with a BMI. You should consider it with a patient with a BMI greater than or equal to 40 kilograms per square meter. Women with sorry, there was a bit of interruption. Women with a history of confirmed VTE should be offered thromboprophylaxis with low molecular weight heparin or warfarin for at least 6 weeks postpartum, regardless of the mode of delivery. Women with a family history of VTE and unidentified thrombophilia should be considered for 6 weeks postnatal thromboprophylaxis. So it is important that we consider that all women who have had cesarean deliveries should be considered for thromboprophylaxis with low molecular weight heparin for 10 days after delivery. So cesarean section by itself is a risk factor. And ideally, and that's what the RCOG recommends, you should give them thromboprophylaxis with low molecular weight heparin for 10 days after delivery. Again, that's a conversation we need to have with the surgeons we work with. Thromboprophylaxis should be continued for 6 weeks in high-risk women and for 10 days in intermediate-risk women, as I've said. Some women with previous recurrent VTE require higher doses of low molecular weight heparin. Now, this is a crowded chart, but this is what the Royal College of Obstetricians and Gynecologists has recommended in their guideline of 2015. So if a patient has any previous VTE, or if anyone is requiring antenatal low molecular weight heparin, or if a patient has high-risk thrombophilia or low-risk thrombophilia with a family history, then treat as high risk and at least 6 weeks, give at least 6 weeks of postnatal prophylactic low molecular weight heparin. Cesarean section in a patient in labor with a BMI greater than 40 kilograms per meter squared, or readmission or prolonged admission more than 3 days in the puerperium, or any surgical procedure in the puerperium except immediate repair of the puerperium or of the perineum. These are some of the things, and medical comorbidities such as cancer, heart failure, as I had said earlier, SLE, IBD, or inflammatory polyarthropathy, nephrotic syndrome, type 2 diabetes with nephropathy, sickle cell disease, current IVDU, and so on. These are patients who are at intermediate risk, and they need at least 10 days of postnatal prophylactic low molecular weight heparin. Note that in persisting or greater than 3 risk pre-existing, or if there is persisting or greater than 3 risk factors, consider extending thromboprophylaxis with low molecular weight heparin for up to 6 weeks. If the age is greater than 35 years, if there is obesity with a high BMI of 30, if the parity is greater than 3, if the patient is a smoker, if it is an elective section, family history of VTE, low risk thrombophilia, gross varicose veins, current systemic infection, immobility such as paraplegia, current preeclampsia, multiple pregnancy, preterm delivery in this pregnancy at less than 37 weeks, and stillbirths in this pregnancy, mid-cavity rotational or operative delivery, and prolonged labor greater than 24 hours, PPH greater than 1 liter, or when you have transfused your patient. These are some of the fewer than 2 risk factors. And this lower risk, early mobilization is all you need. The ones that I've mentioned, you may just need early mobilization and avoidance of dehydration. So, but if you have more than two or more risk factors, you must treat the patient as having intermediate risk. Which agent should be used for thromboprophylaxis? Decisions about anticoagulation in pregnant women must be weighed against risks and benefits to both mother and baby. Available anticoagulants include low molecular weight heparin and fractionated heparin, fondaparinux, low-dose aspirin, warfarin, and non-vitamin K antagonists, oral anticoagulants, the NOACs. So these are available, but which ones do we use? Low molecular weight heparins are the agents of choice for perinatal thromboprophylaxis and are even safe in breastfeeding. Low doses of low molecular weight heparin are based on the weight. And the weight should be either the booking weight or the most recent weight that you can find in the patient's file. Monitor the platelet count if the woman has had prior exposure to unfractionated heparin, because we know of heparin-induced thrombocytopenia. Doses of low molecular weight heparin should be reduced in women with renal impairment. Unfractionated heparin preferred in women at very high risk of thrombosis and may be used in preference to low molecular weight heparin where there is an increased risk of hemorrhage or where regional anesthetic techniques may be required. This is just because you can reverse unfractionated heparin. You cannot reverse low molecular weight heparin. If unfractionated heparin is used after cesarean delivery or other surgery, the platelet count should be monitored every 2 to 3 days from the 4th day to the 14th day or until you stop the heparin. Fondaparinux should not be used, should be reserved for women who are intolerant to heparin compounds. Its use in pregnancy should be in conjunction with a consultant hematologist with expertise in hemostasis and pregnancy. Low-dose aspirin therapy is one of the anticoagulant treatments used during pregnancy. It's one of the drugs they use for patients with recurrent pregnancy losses. Warfarin use in pregnancy is restricted to few situations where heparin is considered unsuitable, e.g. some women with mechanical heart valves. But it has got risk of teratogenicity, and it has also got risks of causing excessive bleeding and must be stopped at some point and replaced with low molecular weight heparin if need be. Oral thrombin and activated factor 10 inhibitors, these are the NOACs, should be avoided in pregnant women, and the use of NOACs is not currently recommended in women who are breastfeeding. So we do not use them. Low molecular weight heparin should be avoided discontinued or postponed in women at risk of bleeding after careful consideration of the balance of the risk of bleeding and thrombosis. Women with previous or current allergic reactions to low molecular weight heparin should also be given an alternative form of prophylaxis. Further advice on the management of a woman with both VTE risk factors and bleeding risk factors or low molecular weight heparin allergy may be sought from a hematologist with expertise in management of thrombosis and bleeding disorders in pregnancy. So always work as a team. You have the obstetrician, you have the hematologist, and you have yourself, so that you consider everything together in total. Low-dose aspirin therapy is one of the anticoagulant treatments used during pregnancy, as I've said. Anticoagulant agents may be useful for several disorders, such as recurrent miscarriage, preeclampsia, fetal growth restriction, and infertility. So you'll find your patients on them. This is in conclusion. Although 70% of recurrent pregnancy losses are unexplained, anticoagulant therapy is effective in maintaining pregnancy in women without antiphospholipid antibody syndrome. Apparently, it improves placental blood flow and therefore improves fetal viability. Low molecular weight heparin is the preferred pharmacologic agent over unfractionated heparin for the treatment of venous thromboembolism in pregnancy. So when you are thinking of venous thromboprophylaxis in pregnancy, the first drug that should come to your mind is low molecular weight heparin. As I said, vitamin K antagonist should only be considered in exceptional circumstances for the treatment of venous thromboembolism in pregnancy, where you are considering a matter of life and death for this patient. You may, with consultation of the experts, decide on it. So I have case scenarios, 2 of them. The first one is a recent one, happened last year. This is a patient who was related to one of our colleagues, and she was a 39-year-old female, para 2+0, who came and underwent elective cesarean delivery. That was in October 2023, under spinal anesthesia, and was discharged home uneventfully on the 3rd postoperative day. The same patient had a history of 2 previous uneventful cesarean deliveries, both under spinal anesthesia. There was no history of previous DVT or family history of DVT. There was no history of chronic medical disorder. Remember the risk profiles that we were talking about. Then, a week or so later, this patient began complaining of general body weakness, and I talked to her on phone to discuss the symptoms that she was complaining about. And the aim was to find out if any of the symptoms could suggest residual neurologic effect of the anesthetic that was given to the patient. This was fairly non-specific. She said that she even all of a sudden felt weakness in her hands and almost dropped the baby. So I just reassured the patient and literally forgot about the patient. 1 week later, I was called and told that that patient developed difficulty in breathing and was rushed to the nearest hospital, which I think turned out to be Mater Hospital. And at Mater, she was diagnosed with pulmonary embolism, and by God's grace, was successfully managed on anticoagulants. This patient was not discharged on any anticoagulants. I'm just wondering, did this patient, because of complaining of that weakness, remain more in bed or immobile, and for that reason developed the DVT, which resulted in thromboembolism? I don't know. It's something that is difficult to tell, but it happened and the patient is alive. Case number 2. This happened over 10 years ago. We had a 45-year-old healthy lady with symptomatic uterine fibroids. She was admitted for TAH, which was successfully done. She was discharged home, active, alive, and well. She was a slim lady with a BMI of about 25 or less. And we had prescribed early mobilization, and she was very active. There was no previous history of DVT or any chronic medical condition. And even the uterus that was removed was non-malignant. This same patient collapsed while shopping at a local supermarket after 3 weeks from the time we discharged her. She was rushed to the nearest hospital, which was Nairobi West at that time, but was pronounced dead on arrival. Post-mortem report stated that she died from massive pulmonary embolism. What messages do we take home? Deep vein thrombosis is completely treatable if caught in time, but the symptoms aren't always easy to spot. It is important to identify which patients are most likely to develop VTE ahead of time and decide on what prophylaxis to institute, whether mechanical or anticoagulant or both. In the US, we said that they have introduced a performance measure for VTE prophylaxis in all hospitalized medical patients. This measure requires that clinicians to either provide VTE prophylaxis or document reasons for omitting it. Is this the way we should go? Are we being overly anxious or paranoid when we say we should begin thinking of giving our patients VTE prophylaxis after surgery or after delivery? That is the point I have, and that is my talk. So I am done, and I go back to the moderator to tell us what next. Thank you.
Thank you, Dr. for a very precise, elaborate presentation on VTE. This is supposed to be an interactive session, and I see already we have something, people are writing on the chat box. As of now, I'd like to invite our sponsor for the day, Sanofi, who have graciously sponsored our meeting, to say a keynote, then we can go into the interactive session. Thank you.
Thank you so much, Dr. Gesare, for moderating this session, and thank you, KSA, for giving us this platform. I would love to share my screen, and thank you, Dr. Olang, for that awesome presentation. We cannot appreciate it more, and I don't think I can say more than that, but I'd love to at least share a bit of something from my end. Kindly let me know once you can see my screen. Dr. Olang, I think you should stop sharing. Can you see my screen?
Not yet.
Okay, okay. Okay, just a moment. Sorry, we had some few of hiccups today on our end, but I think more is sorted out. Can you see my screen now? Sorry, I'm using my
Yes.
phone. Yeah, I had to switch devices, but I hope this works. We are good?
We are good, but you have to...
Can you see now?
Yes, now we can see.
Okay. So good evening again to everyone. My name is Spirit Njeri. I work with Sanofi, and we are happy to be with you here today and to be a part of this discussion on VTE and to re-emphasize on the safety that should be taken in our hospital to ensure that we prevent PEs, as Dr. Olang has already said. You can see some of the instances whereby if we had prophylaxis, we could have prevented PE. The objective of my presentation today is at least to remind you to gather an understanding of the burden of VTE, which Dr. Olang has really done a quite good job in terms of that, and also to understand how to achieve adequate prophylaxis for the patient at risk of VTE and minimize the deaths that are related to VTE, and also maybe have a look at injection technique while using our low molecular weight heparin. So VTE is often silent in nature. As you can see from the previous cases that were presented for the patients, we saw that those patients did not present with any symptoms. And this can be seen quite well in this form of an iceberg, where only 10 to 20% show the symptoms and 80 to 90% are usually without symptoms. Therefore, it is usually difficult to diagnose as there is lack of routinely performed postmortem. So most of the times we might miss the deaths that are caused by PEs, and we are not able to know how many of the patients are lost by PEs unless we do postmortems. This is just another image just to re-emphasize on how that 10 to 20% of the symptoms of VT is only what we are able to see. Therefore, there is the need for us to use the Caprini scoring tool and also to be able to do risk assessment to be able to tell if our patient is at risk of developing a clot. Therefore, we are able to prophylax or even to treat in time to prevent any type of pulmonary embolism. Moving on, I'll talk about a study that was done by Endos. This was done by Lancet, the Endos study that was done by Lancet in the year 2008. It was to look at the patients in the hospital setup who are at risk of DVT. This could be your surgically ill patients or even a surgical patient or even your medically ill patient. And according to the Endos study, it showed that pulmonary embolism, it accounts to 5 to 10% of the deaths in the hospitalized patients. And this makes VTE the most common preventable cause of death in the hospital setup. In addition to the acute risk of mortality, VTE is associated with long-term risk of post-thrombotic syndrome or even chronic thromboembolic pulmonary hypertension. Therefore, there is a need for us to be able to understand and to be able to tell on when to initiate prophylaxis in order to prevent this type of events from taking place in our patients. These were the results of the Endos study, and I'll just go down briefly to look at the surgical patients. We can see that 64% of the surgically ill patients were at risk of developing a clot, and only 59% did receive the ACCP recommended prophylaxis. Therefore, there was a gap and there was a miss in terms of the patients who received prophylaxis. So with that, Endos pushed the data in terms that VTE is often preventable disease, which causes morbidity and mortality among the hospitalized, either medical or surgical patients. And many complications and deaths due to VTE could be prevented using the appropriate thromboprophylaxis. Therefore, it shows that there is need for us to implement hospital-wide strategies that will help to systematically risk assess our patients for VTE and therefore be able to provide the appropriate VTE prophylaxis. And this could be like using the Caprini scoring tool. If it is incorporated in the hospital setup, then we can be able to do risk assessment all the way from the triage up to the admission and even on the patients when they are being discharged. Therefore, we'll be able to tell which of our patients are at risk, and it will help to improve patient safety in your hospitals. With us at Sanofi, we have a drug, a low molecular weight heparin. I know most of us have used it, have seen it, and have seen Clexane in the hospitals. It is the enoxaparin sodium that has been proven to be predictable in the prevention in VTE management and even in treatment. Clexane mode of action, it works as a factor 10A inhibitor and a factor 2 inhibitor on a ratio of 3:1, thereby it prevents the formation of clots. It doesn't do lysis, but rather it prevents the formation of these clots. Mechanism of action of Clexane, as I have said before, it exerts its antithrombotic effect by inhibiting the activity of the two key factors, that is factor 10A and factor 2A, which is thrombin, and more of its effect is felt on the factor 10A rather than a thrombin inhibitor. Therefore, it is able to prevent production of thrombin down the stream, and Clexane is one of the most commonly used low molecular weight heparin and has been approved for many indications in comparison to unfractionated heparin. Clexane has been provided with decades of clinical evidence in different indications, whereby it has been patented through studies, and it has been shown to be well equipped in the prevention and even in treatment, from DVT prophylaxis in hip replacement surgery to knee replacement surgery, all the way to treatment of acute STEMI patients who are being managed medically with or without PCI. And this is also done for prophylaxis with medically ill patients, for your patients who are in the hospital setup who might need prophylaxis or who are being treated as well for DVT. Clexane has been patented and licensed and has been shown to have data that supports it in terms of its efficacy and how it can be used in these indications. This is some of the studies that have been done using Clexane for your different indications, all the way starting from medically ill patients. And I know of interest to you mostly, it will be for the surgeries. And in orthopedic surgery, we have the BACVAS trial, and in the general surgery, we have the Noxacan trial. In treatment, we have the Levine et al. And ACS treatment, we have sorry, apologies for that. We have the TIMI 11B trial. Moving on, I'll talk about one of these studies. We have Clexane that has been used in abdominal surgery, and we have the Noxacan study. And I'll just be brief about this, just to look at a group of patients that were grouped in this study. Patients who are above 40 years, who are 40 years and above, with a life expectancy of more than 6 months, who are to undergo surgery for malignant tumors of the GI, genitourinary tract, or female reproductive organs, surgeries to either take 45 minutes or more and under general anesthesia. Randomization of this study, it was using enoxaparin 40 mg or a placebo, the placebo being unfractionated heparin. The endpoints of this study, the primary endpoint was if the patients develop VTE between 25 to 31 days after surgery, and the secondary endpoint was bleeding during the 3 weeks after randomization. And these were the results, and you can see that for all these indications, Clexane did very well, and the risk was really reduced for patients who on Clexane as compared to those on using unfractionated heparin. Patients who came back presenting with PE, they were 0 in comparison to the 1.2 using the placebo. So these are the indications where we recommend Clexane for surgical, in surgical cases when you're doing cancer surgery, as cancer patients have a higher risk of developing DVT, and this has been the second leading cause of death for patients with overt malignant disease. And you can see that the risk usually goes low from day 16 to 20, but the risk is relatively increased all the way from day 30 and more. Therefore, we recommend as Sanofi that Clexane for your surgical, for your cancer surgery, after surgery, that you give Clexane for at least 3 months for these patients to prevent any type of DVT or a PE from coming up. For your orthopedic cases, you should stop Clexane according to the ACCP guidelines 12 hours before surgery, and then initiate again 12 hours after surgery, and continue giving prophylaxis daily for at least 3 weeks or until the risk for developing a clot still persists. And for your patients who are already diagnosed with a DVT, when you are doing treatment, we recommend that you give Clexane 1 mg per kg every other 12 hours, that is BD, or at least until the risk is taken care of, or once daily for 10 days. I hope that is very clear. And in spinal anesthesia, as Dr. Olang had already said, I'll just do a re-emphasis. When you are using Clexane in the context of either epidural or spinal anesthesia, you should show extreme vigilance, and frequent monitoring must be exercised to detect any symptoms and signs of neurological impairment. This is very important, especially in this session as we are dealing with anesthetists. Placement or removal of a catheter should be delayed for 10 to 12 hours for administration of DVT prophylactic doses of Clexane. And the subsequent Clexane dose should be given no sooner than 2 hours after the catheter removal. I hope that is very clear. And if it's not, I think Dr. Olang will take questions in regards to that. The recommended doses in surgery, when you're giving Clexane, as I said before, you should stop it 12 hours before surgery, and then give the next dose 12 to 24 hours post surgery. And then depending on the risk of your patient, you can give from 7 to 10 days after surgery, or until the risk is, or until the patient is, the risk is taken care of. Now, this would be a question to everyone, to us even as well. And some of the misconceptions that have been seen about thromboprophylaxis is that the risk of VTE has decreased over the years to the point where routine thromboprophylaxis is no longer needed. And I would answer for myself and say no, as seen from the previous case that Dr. Olang has presented, and he has showed that there is still need for us to do prophylaxis after every other surgery. And as autopsy data continues to show that the PEs to be a major cause of death in patients undergoing surgery, as according to the 2 cases, at least one of our patients was well diagnosed and was saved. But for the other one, it was a different story. So therefore, we should give prophylaxis every now and then, and not avoid prophylaxis. Is the risk of bleeding from anticoagulants, does it outweigh the benefits of routine thromboprophylaxis? And I think this will depend on you as a doctor. But if you see that the risk of bleeding is higher, then you can opt to go with the mechanical methods, and this as well might also be able to take care of the risk of VTE. The thirdly and last thing is that the cost of thromboprophylaxis prohibits its routine use, and economic studies have shown that and demonstrated that routine thromboprophylaxis is cost effective, particularly when long-term implications of VTE are considered. For example, PEs. So if we take care of the VTE by prophylaxis, then we're able to prevent PEs, which there is no cost when buying back alive, and we cannot be able to buy back alive. So we'll rather experience the cost, but able to save lives and also prevent things like post-thrombotic syndromes. That would be my message. And in this market and era, I would also like to ask about if low molecular weight heparins are the same. And Clexane by itself is a biologic, like erythropoietin, like insulin, and like monoclonal antibodies, and it falls in this category, as it also elicits an immune response. Therefore, every other low molecular weight heparin that is out there that is a biologic should be able to fall into this category and tick all the boxes in these characteristics. If it doesn't, then it's another story. So can you interchange low molecular weight heparin one from the other? And the answer is no, according to the ACCP guidelines. And it states that these products, they are prepared differently under different chemical methods, and each product is different and cannot be used on a unit-to-unit basis and cannot be interchanged from any other. And the product is the process on how it is made, as each low molecular weight heparin has a specified temperature, base concentration, and duration factors in the reaction, which can be affected if the chemical structure is changed or altered. So therefore, low molecular weight heparin are non-interchangeable biological molecules. So if you use Clexane for your patient, you start with Clexane, you have to go all the way with Clexane. You cannot change or interchange it with any other low molecular weight heparin. So why Clexane and not any other, or unfractionated heparin or any other low molecular weight heparin? Clexane has been shown to have improved bioavailability, that is predictable anti-thrombotic effect, has a longer half-life, and can be conveniently dosed either BD or OD depending on the indication, and has less binding to blood proteins. Therefore, we have fewer side effects such as bleeding, which is quite low when using Clexane. And while using Clexane, there is no need to do routine monitoring, as the dose and the normal baseline coagulation parameters are already known. Therefore, Clexane is a drug that you can use that has already been recommended and backed up by data. And you can see even in comparison to the NOACs, it still wins, even for your patients who are pregnancy, where you cannot use NOACs, then you can always you can always go for Clexane. So these are some of the doses. We have Clexane 40. I know this is what we mostly see, our most commonly used prophylactic dose. We have also other doses. We have Clexane 20, which comes in color code white. We have Clexane 40, which comes in yellow. Clexane 60 and 80 are usually orange and brown, and these are our treatment doses that you can give for your patients who are diagnosed with DVT for treatment. And this treatment is usually twice a day, BD, while using Clexane. These are some of the contraindications whereby we don't recommend the use of Clexane. If your patient has an active bleeding site, they have hypersensitivity to benzyl alcohol. If they have any side effects or have been shown to have side effects to heparin, then you cannot use Clexane. Heparin associated thrombocytopenia, and also Clexane should be avoided in patients with at risk of hemorrhage, patients who have hemorrhagic blood disorders, thrombocytopenia, peptic ulcers, cerebrovascular disorders, infective endocarditis, and severe or uncontrolled hypertension. So in conclusion, I'll just show you a photo about the injection technique. We need to make a pinch and inject Clexane at a 90-degree angle, not 45, not 60, at a 90-degree angle, and make sure that the whole dose is given. And while you are discharging your patients as they go home, please remind them that Clexane comes with an air bubble, and this air bubble should not be dispensed. Should inject with it as it is. And that is the end of my presentation. Thank you, Dr. Gesare and Dr. Olang. I'll pass back the meeting to you. And Clexane is available in all major hospitals in Nairobi and even outside Nairobi. Thank you so much for your time. Thank you.
Thank you, Purity. I want to take a moment to thank you and the team back at Sanofi for sponsoring us. And we at KSA, we appreciate the partnership that we have with Sanofi this far. We are happy. So now I think, let me go to the chat. I've seen that there are many messages. I'll start with Dr. Janak. He says, sorry, thank you very much, Dr. Lang, for an excellent presentation. The next comment is by Dr. Oure. What might be the outcome if you start prophylactic dose after thrombosis was quietly developing, i.e., one started the prophylaxis late? I think this is a question to Dr. Olang.
Yes, if there is already a thrombus, your Clexane is not going to help you. It's not going to thrombolize, but it's going to prevent any further formation of thrombosis. But if that thrombus is diagnosed, then thrombolysis is necessary. That's the best way of dealing with the thrombus, because the moment it has been diagnosed, then it needs to be thrombolized. It has been to be removed either chemically or mechanically. And it doesn't matter whether the patient is pregnant or not pregnant.
Okay. Dr. Kerio is asking, considering that most CS patients, you meet them with a client the day of the surgery or a day before surgery, at what point then do you start prophylaxis?
The prophylaxis is started after surgery. You don't start it before surgery. If your patient comes, you meet the patient when the patient has not been on any prophylaxis. You start that after surgery, and we have been told you can start up to 12 to 24 hours after surgery.
Dr. Kasembeli is asking, how accurate is anatomical postmortem in picking out PTE, especially in maternal mortality?
It's actually very active, very accurate. I've discussed with the pathologists, and they say if there is a thrombus, they will actually see it in the pulmonary vessels. So that is definite. It is very accurate once the patient goes for postmortem. And of course, just the way when we do CTPA, we are able to detect if there is already embolism. If the patient is alive and has gone for CTPA, they are able to still be able to identify the thrombosis, and then they can thrombolize the patient, and many of them, of course, will survive.
Dr. Ure is asking, when dosing prophylaxis in pregnancy or postpartum, which weight does one use? Do we use a pre-pregnancy weight or at term weight?
You use the weight at admission or the latest weight. So you will use the pregnancy weight most times. Unless, of course, you don't have a weight, then you will have to estimate the weight, and the patient will tell you which, when the last time she was weighed, how much she weighed, and that's the weight you use.
Dr. Ngu thanks you, Dr. Olang, for an excellent presentation. And our question is, what is your take, Daktari, on thrombolysis in pregnancy and puerperium?
There's no contraindication of thrombolysis, knowing very well, of course, thrombolysis is a major is a major procedure in the sense that some patients react badly to it. But if your patient has a thrombus, that thrombus must be dissolved, and it must be dissolved as soon as possible because of the possible consequences that it may have. So you will not withhold the thrombolysis.
Okay, so we can use streptokinase for thrombolysis.
Yes.
Then Dr. Gaderu is reminding us of our dear late colleague, Eunice Songa. Thanks for the great talk.
Yes, Eunice had they had a DVT that was not diagnosed. It was diagnosed at death, unfortunately.
Dr. Ure is doing a follow-up on the weight. So she's asking, so I've been dosing and I've been underdosing as all most non-obese women post CS at 40 milligrams. Is that an underdose or?
Actually, depending on the weight of the patient, unless you are treating the patient, of course, if you give all your patients a dose of 40, then you might not be right. But thromboprophylaxis is weight dependent, and I don't know. The thing is that I think it has a wide margin of safety, but I leave it to Purity to answer that. Don't you think, Purity, that 40 milligrams of Clexane in a patient who is, say, 50 to 60 kilograms will do for thromboprophylaxis? Because I know it has a wide margin of safety, and you don't want to give too much of the drug.
Yes, Dr. Olang. Depending on the weight, like for your obese patient, it will depend on what you quantify as the BMI on admission. Like Dr. Olang has said, if the BMI is high, then you need to do a higher dose. But for your patient who is 50, 60, on average 70, that is a normal weight, and you can give the 40 mg for prophylaxis. If the BMI is higher, then you need to do 60, might be more appropriate in terms of prophylaxis. What do you think, Dr. Olang? I think that would be my most appropriate answer.
I'm in agreement.
Yes.
That's what we practice, and it
Yes.
works.
Dr. Njogu is asking, thrombolysis post-neurosurgery, is it contraindicated?
That is a difficult question. Post-neurosurgery, if it was neurosurgery with a bleed, then it is tricky. If it was neurosurgery without a bleed and your patient has a thrombus, it may be acceptable. But this again is where your teamwork comes in. You discuss with your surgeon and you discuss with your hematologist and you agree on what is appropriate. But I don't think that it is an easy question to answer at this stage. So I'll probably leave it at that.
Dr. Pascal is inquiring, do we have data on mechanical VTE prophylaxis effectiveness? Oh, sorry, before you can answer that, Dr. Njogu has raised his hand. Dr. Njogu?
Yeah, I just wanted to clarify that the thrombolysis post-neurosurgical procedure, and particularly within the first month of the surgery, is actually contraindicated. It was a statement. And I have had an experience of at one point where we had a patient who actually got DVT and got PE, and an aggressive cardiologist rushed in and treating the PT just like for any other patient and gave thrombolysis.